So today we are going to discuss a very common pediatric topic, that is physiologic anemia of infancy. Myself, Dr. Asif Ali, working as a child specialist. So this is a brief overview. Full-term in newborns have high hemoglobin level, large RBCs. Progressive hemoglobin decline start within the first week and continues for the 6 to 8 week, called upon physiological anemia of infancy. What is the pathophysiology at birth? Oxygen saturation rises from 50 to 95%. Increased oxygen availability. Switch from hemoglobin F, means fetal hemoglobin, to hemoglobin A. So hemoglobin A has lower oxygen affinity, improves tissue oxygen delivery, result in decreased erythropoietin production, leads to suppressed erythropoiesis. Hemoglobin nadir in term infant, no new RBC production. It results in hemoglobin fall, nadir reached at 8 to 12 weeks. Average hemoglobin 11 gram per deciliter, rarely falls below 10 gram per deciliter. Once tissue oxygen demand exceeds delivery, erythropoietin rises and erythropoiesis resumes. Iron availability. So iron recycled from degraded RBC reticuloendothelial iron is stored sufficient until 20 weeks of the age. Dietary iron not required during this phase. Clinical significance. Normal physiologic adaptation reflects excess oxygen delivery versus tissue demand. Not a disease. No treatment required. Treatment only if worsened by nutritional deficiency, blood loss, hemolysis. Factors exaggerating physiologic anemia, low maternal hemoglobin, hemolytic disease of newborn, persistent maternal anti-RBC antibodies, late hyporegenerative anemia, prior intrauterine or neonatal transfusion, adult hemoglobin A, increased oxygen delivery. Anemia definition depends on hemoglobin level, oxygen requirement, and tissue delivery. Anemia of prematurity occurs in preterm infants, more severe and rapid hemoglobin decline. Hemoglobin nitrate is 7 to 9 gram per deciliter, reached by 3 to 6 weeks, even lower in very low birth weight infants. Pathophysiology in prematurity, same mechanism says the term infants but exaggerated. Additional contributors are frequent phlebotomy losses, shortened RBC lifespan, that is 40 to 60 days, rapid growth, increased RBC demand, and inappropriately low erythropoietin levels. Causes of low EPO in preterm infants. Fetal EPO or erythropoietin produced mainly by liver. Liver less sensitive to hypoxia than kidney. Transition to liver EPO production not accelerated. Possible accelerated EPO metabolism. Clinical importance. Anemia of premature not benign. May cause apnea, poor feeding, tachycardia, often require transfusion when symptomatic. Treatment. Term infant, no treatment for physiologic anemia. Ensure adequate nutrition. Exclusive breastfeed infant. Start iron supplement at 4 months. Continue until dietary iron is adequate. Treatment in terms of preterm infant, optimal hemoglobin level individualized, transfusion if symptomatic, feeding well and growing normally. Usually no transfusion unless blood loss is significant. Restrictive transfusion strategy preferred. No increase in morbidity, mortality, better neurodevelopmental outcomes. Risk of liberal transfusion, poor long-term neurodevelopment, increased risk of necrotizing enterocolitis, intraventricular hemorrhage. Iron supplementation in prematurity start 2 to 6 weeks of age, continue until 6 to 12 months, dose based on birth weight, smaller infants, higher doses, all infants with anemia of prematurity, iron from 1 month to 1 year. Preventive strategies, delayed cord clamping, minimizing unnecessary blood sampling, adequate iron supplementation. Delayed cord clamping benefits, fewer transfusion, decrease intraventricular hemorrhage, decrease necrotizing enterocolitis, especially beneficial in from infants. Transfusion guidelines are the PET cell or PET's RBC volume 10 to 15 ml per kg. Split donor units recommended. Minimize donor exposure. So thank you very much. This is the final slide, and please follow my page. Thank you.